Thank you so much. It's a great honor for me to be here, and I will try to be brief and very short. And if I'm not short enough, you have to stop me. And I will try not to speak overly fast, so you can follow my Swinglish, as we say in Sweden, that we have this wonderful language of Swinglish. Thank you so much for inviting me. I would also like to add that it's my first time ever in India, so even though I arrived very late yesterday, I am very happy to be here, and I've been met by so many nice people, and I feel very comfortable here. So thank you very much for inviting me and for allowing me to say a couple of words here at this very important fora. How do I do to get this up? Should I just duplicate, maybe? Good. It was very simple. So I would just like to say a couple of words about WFAD and what we are trying to do, what we are trying to prioritize. And as mentioned here before, I will focus a bit on prevention to try to have something to say on that. WFAD is a membership organization. We have over 200 members from all over the world. We were founded in Sweden, but right now our majority of member organizations are based in Asia and in Africa. So we are now dominated by organizations coming from the global south. But we are based in Sweden from a reason, and that was when we were founded, we wanted to highlight the drug policy of Sweden. And this is something that we still are trying to stress. Not because the drug policy of Sweden is a perfect one, but Sweden has always had a great focus on prevention, and we have always had a great focus on treatment, and we have always had a great focus on a restrictive drug policy to keep it together. And restrictiveness should not be confused with being repressive. It's about restricting the drugs that are being in the society. So that was why we were founded in Sweden. But for not being but the organization should not be Swedish. So therefore it's in our statutes that we should have 2 board members from each continent. So we have 2 from Oceania, 2 from Africa, 2 from Latin America, 2 from North America, 2 from Europe, and 2 representing Sweden. And Diana was just newly elected in May 2018 here on our Congress to be the representative of Asia, which I'm super happy that you are. So you have a strong voice inside the WFAD. And we have 2 goals of WFAD, and one is to influence the global debate on drug policy, to bring out the voices of our members, and to enable our members to speak on the global debate on drug policy, which is highly important. Because when politicians meet and they discuss drug policy, we also have to bring out the grassroots and to have their voices being heard when important decisions about the future of our drug policy is being heard. So this is what we try to do. That is why I'm in this fancy civil society task force on drugs to prepare the high-level meeting for 2019. It is to make sure that the grassroots and the members of WFAD is being heard in that process. And we're also trying to coordinate all the different views and to have statements around different areas. And this is a very nice picture behind me from the last meeting at the UNODC, which was mentioned here earlier by Father Chris, the United Nations Office on Drugs and Crime. And this is what we are trying to promote, the slogans we are trying to easily adapt here. And the first one is to prevent, not promote. And maybe this is the most important one, because I think we can all agree that drug policy should stand pretty firmly on prevention. It's easier to prevent than to try to fix. But in order to do that, we also say that we need to mobilize community. And that is also a reason why I'm very happy to be here today, because I can see that there is a lot of different stakeholders here. And even though I strongly believe in the power of NGOs and what we can do, we still need to work with other areas of the society, and the NGOs need to cooperate with each other. So and the mobilization part is the one that is easy to write, but it's so difficult to do in practice. We can talk about cooperation and doing things together, but when it comes to reality, it's about prioritizing, and it's about actually finding someone to do it with. So, but we also know, we can see it from the Icelandic model, we can see it from best practices when doing recovery work, that you get the best outcome when you work together and get several agencies to go to the same goal. But then there is the tricky part, then you have to have the same goal within the organizations, and maybe that is one of the reasons why it sometimes can be difficult. And the third slogan we are trying to push is to rediscover recovery. And someone here earlier at one panel said that it is a problem with the stigma that people in recovery are facing coming back, and this is very important. We have to believe in recovery, and we have to enable them to come back and be contributing members of the society. And in order for them to be able to come back, we have to have the structures and our mindset to be able to do that. So this is also something that we are really trying to push, and we are trying to push it in many different ways. One thing that I think is very interesting is to do surveys that has been done showing that people in recovery have a great mental and physical health, but they are also volunteering and contributing more to society than the general population, which I think is something that we should take advantage of, and the recovery movement is very important to be used in enabling more people coming into recovery. I want to say a couple of words around the schools and the prevention being done in the schools, because I think that is what the last panel was about. But if I could just comment on one small thing, I think this is one of the crucial ways that we can and should work to keep our schools drug-free. And the best way to do that is to have a good school. And a good school, I think everybody wants to have. So we also need to have drug-specific activities within the school. We need to have a drug policy for the school. We need to have action plans. And here again, we need to connect with other resources in the society so we can help the people who actually have a problem with drugs to get help and support that they need if the school structures and the school support system is not enough. And this is a way where we work in Sweden, and just one example which is very much in line with the Icelandic model is that we do drug surveys in Sweden, but where I come from, Gothenburg, we also break them down, and we break them down on a school level. So we can see the different schools in Gothenburg. Some of them has almost none. They have maybe one person tried cannabis once, and other school has a huge problem with cannabis use. It's come up to the point where it's normalized within that school to use cannabis. But when we break down the statistic like this, and we also break down the risk and protective factors that we have in our drug survey, we know where to work, how to prioritize, and how to lessen the risk factors and strengthen the protective factors. And we know that we should work in this school because they have a high prevalence of drug. And they have such a high prevalence, so it's normalized to use drug. I can imagine that my time is up, but I will say one more thing that we see as a huge threat to our schools and our kids and the society as a whole, and that is the movement that we see coming from North America and now lately from the US, some states, and also from Canada, and that is the trend of legalization of cannabis, which I think would be a very bad way to move forward in the global drug policy, and I hope we can put a stop to this. And one of the reasons for that is when I go around and talk to our members of WFAD, they say that this is a Western ID. We don't have the facility
to target the interventions locally and in a focused manner, and also towards we have an experienced public servant here. He has been the He has served as the director of Doordarshan Trivandrum and All India Radio Trichy, and currently he is the director of Public Relations Area Development Corporation. Let's listen eagerly to his dreams and what he has thought up to make Kerala drug-free.
Thank you and good evening to all. A small correction, I was the director of Information and Public Relations.
Thank you.
No more the director of that. And what can be the long term strategies and all, those things can be discussed in the next session. Here actually I am limiting myself to the specific topic which we are discussing in this session. One of the most important issues which we are facing, we are trying to address this serious menace of alcohol or substance abuse, is that everybody coming across to you has a solution to offer. And everybody believes that that is the correct solution. And this is an issue with all problems. I can always say that when I was sitting in that office, every day people used to come. Some people just walk in, some people are coming with recommendations, and they say that, sir, I have made a short film. This is that short film. It may be a 1-minute film, 30 minutes film. We have to, while identifying the problem, first we have to understand, if we are devising a message, how we can reach it. The doctor was saying, and if we take the things in Kerala, and probably in our country, we are having a serious problem of getting appropriate data. And that is mainly because we don't have done very good research in these areas. We exactly don't know what are the real problems. Very authentic data, which will give us very to the problem which we are trying to address. After insights, then only we have to think of ideas. As they say, it is insights, ideas, implementation, and then impact. Over this, where the government, the non-governmental organizations, and quasi-governmental institutions, mechanism. We will be doing some sort of curiosity to know whether we should have a mechanism in which we say to them, we tell to them, or whether we should have a mechanism in which we listen to them. I think that United Nations have realized this, and that is why I think they have changed the whole concept into listen first. We have to listen to our children, but listen to our youth. Then only we will be able to devise appropriate school level, college level, and community level interventions and activations, so that their energy can be channelized in different other ways, so that this addiction will not happen. I just want to conclude by giving a small example which we tried. I don't know whether these things are successful, because Project Subodham itself could not take off in the way we have envisaged it. So, the New Year was there in 2016. And as we all know, there are New Year parties, there are DJ parties in which they run high, probably on liquor and sometimes on drugs. So we thought that we will organize a mega event in Kochi, in Darbar Hall ground. And I was happy that around 5,000 people, including families, turned up. It was a drug and alcohol-free New Year DJ party. So we thought that let us not say, not to go, not to have fun, not to have pleasure, but you have fun. But at the same time, you have it in a way where it can be safe. So the whole idea was that not to deny them the opportunities to enjoy, but to make them aware there are opportunities for them to enjoy it in a safe manner. So I think that rather than going hammer and tongs on saying, being the naysayers, I think we should, when we are trying to address youth and children, we should devise more and more child-friendly mechanisms so that the messages are taken by them without any sort of filters. Thank you.
Thank you, sir, for highlighting the planned approach to address the issue of drug abuse, drug use by children through proper research, gaining insights, planning, implementation, impact assessment, and also to do the entire thing through child participation, listening to them and doing, honoring their need for enjoyment, but through safe and holistic ways. Now we have the opportunity to listen to Dr. Sanju George. The other day, I was meeting up with someone and she introduced herself as a nursing tutor, nursing educator. Then she told me there are nursing educators and there are bedside nurses. Here we have a psychiatrist who prefers to spend time individually with people who need his help, particularly younger people who are either addicted to substances or to addictive behavior, gaming and the like. Doctor has spent enormous time being a clinician, researcher and consultant in dealing with these areas. Looking at the list of things that he is specialized in, it looks as if all of us also can seek help from him, because he deals with de-addiction with regard to gaming, alcohol, gambling and behavioral addictions too. So let's listen to Dr. Sanju George.
Thank you, sir. I'm a man of few words, tend to listen more and talk less, plus it's getting late in the day, so I limit myself to a few observations, kind of summarize what people have said. I don't think I have anything new to offer in terms of insights. I'm not going to say anything that you haven't heard of or thought about. The first thing probably to say is more young people in Kochi are using drugs than ever before. When I left Kochi in 1999 for the UK and came back in 2015, after 15 years, the scene had changed. And this is borne out by research. We carried out in 2015 one of the largest pieces of research in India, looking at about 11,000 school and college students in the district of Ernakulam, and found that drug use had gone up tremendously. And what we need to remember is alcohol and tobacco are still the most commonly used drugs or substances. 1 in 5 college students had smoked in the past 12 months. 1 in 4 had had a drink in the past 3 months. Whereas if you look at things like, say, cannabis or injectable drugs or cocaine, the numbers are small. I know it makes more sensationalist news when we are talking about harder drugs, so-called hard drugs or harder drugs. But in terms of numbers, we still should not shy away from addressing issues related to alcohol and tobacco, because that's where huge numbers are coming. And I think substance use, for it to generate the interest, attention, intervention and resources, it needs to be a public health priority. It takes time for it to be on policymakers' agenda. It took me 15 years to get gambling addiction on the UK government's agenda, but we will get there. And that's where organizations like Venda, under Diana's leadership, will get there. It takes time. We are in it for the long run. There's no short-term measures or short-term wins, but eventually we can save lives. Prevention strategies, Linda talked about it briefly. For any public health approach to be successful, prevention strategies need to be across the 3 tiers of primary prevention that include things like supply reduction, demand reduction, policy measures, law enforcement, so awareness programs that we do a lot at Venda, so on and so forth. And secondary prevention, smaller numbers but higher intensity interventions. That's brief interventions, psychological and medical, early detection, screening, and so on and so forth. And then comes the high intensity, low volume intervention, tertiary level of interventions or prevention measures, such as rehab centers, long-term medical and psychological treatments for the more severely addicted patients. So for any comprehensive strategy that ought to be, if it has to be effective, you need to think of these holistic interventions at all levels and not just do one to the exclusion of the other. And again, Ambadi sir talked about the need for research as a basis for good interventions to come out. So what we need to remember is evidence-based interventions. What we need to offer are interventions that have a solid research evidence backing it, saying this will work and this is how much it will cost. That's the best way to sell, in my experience, to sell any intervention to the government. We told the UK government, you invest £1 in drug prevention strategies, you can save £9 in 3 years. It's difficult not to buy such an argument if it's backed up by solid research evidence that you can present to them. Whereas if you're a bit airy-fairy about how wonderful your intervention is, it's often difficult to make such a solid case. And again, one other thing that is terribly important will be to ensure sustainability of services and to make sure that services are joined up. There are lots of well-intentioned people, agencies, especially NGOs, but I think currently in the district of Ernakulam, at least some services are a bit disjointed. We do a lot of work at Venda. There are many other agencies wanting to do good, trying to do good. So if these things can come together into a coherent whole, where we all sing from the same hymn sheet, so to speak. So trying to bring all these together, what do we need? And what we hoped will have at least initial ideas to create a roadmap. The bare minimum we need is a think tank. There are several experts from various fields sitting together, but I think it's important that we come together on a regular basis in drawing up the roadmap. And a major challenge will be not just in having a vision. And I think between talking the talk and walking the walk, talking the talk is very often the easier thing to do. It's important. Your voice has to be heard in certain fora, but it's more of a challenge on the ground for clinicians like us who work with addicts trying to save lives. Let's all be realistic. We're not trying to eradicate drug misuse. No country in the world has successfully eradicated drug misuse or substance misuse. So we are trying to minimize the harm and the impact, the adverse consequences it has on patients and families. So start off with a think tank, have a clear vision, and have measures in place to translate that vision or wider strategy. How do we operationalize it and make things happen? And there, I think, again, whether it's a UK model or a Swedish model or an Icelandic model, I think across the world what seems to work in this field is multi-agency partnership. And ideally a public sector, private sector, plus NGOs, a partnership. As to who takes the lead, who takes the primary accountability, who then tenders out services or subcommission services, that can be debated. But multi-agency partnership working, I think in my 20 years of de-addiction experience of working in this field, both here and abroad, I think for it to translate into an effective, efficient, value for money service, we really should be looking at multi-agency partnership, drawing on stakeholders from all the agencies that have had their representation here today. Some haven't been able to come. So I think that will be the challenge, and that will be that can set a solid foundation stone for journey for the next 5 years and longer. Thank you.
Thank Dr. Sanchu for bringing us an entire range of approaches to address the phenomenon of drug abuse. He has told us to address the most prevalent and common drugs that are being used, especially alcohol, in our city, and then the primary, tertiary, and the secondary interventions. And also to have a roadmap, and he stressed also that we need to minimize the harm through preventive measures and maximize on the benefit for the targeted population. And also told us that the most effective approach is the multi-agency approach with partnership between the governmental, semi-governmental and non-governmental agencies. Thank you, Doctor, for that. And in that comment, you have also concurred with Sri Ambadi about the level approach and also the multi-agency approach, non-governmental and governmental agencies. We have a few queries that have come in. The first query is to Dr. Harish Pillai. With the largest pediatric base and also adolescent health department in Kochi, what would be Asta Medicita's plan to cater to teens and young adults, especially in the recovery program? What specific measures you have in mind?
From a very humble point of view, what we realize is that just provisioning of infrastructure and human resources is just not enough. We need a lot to learn, and I don't think one institution can make much of an impact. I'm quite encouraged by what Ambadi and Dr. George just mentioned, that I hope along with Diana and all of us together, we need to all join hands. Clearly the pathway forward is not for an individual organization, but for multi-stakeholder collaborative effort. We have just 14 districts, and I'm quite sure that an agency like the Indian Medical Association, which has got a large network of clinicians and clinical resources, educators, all of us need to come together and talk about it. And I like what Ambadi talked about, listening. I guess that's the most important thing, that we first now need to listen to each other, and only by listening to the future of our country can we really understand why are they so disturbed. One more comment I have is that this is nothing to do with, it's a social reflection. When I read newspapers, like we as a society in Kerala, we're so obsessed with rankings. Like I'm in the healthcare sector, so I can tell you the NEET ranking, national, anyone who gets the 10+1 ranks, everyone seems to advertise them as superstars. This obsession of, in Hindi we have a saying that Jo Jeeta Wahi Sikandar. I think we need to break down that kind of obsession with being number 1, number 2, number 3. I want to celebrate the backbenchers. Because our educational system itself you need to put an atom bomb into our educational system. This entire obsession with ranking and rote learning, that it's all memory based. And I have seen from my experience in medical school that the most brilliant doctors are not necessarily who got the number 1 rank in the entrance exam. Those naughty boys and girls at the backbenchers who throw rockets at professors, they land up being the most brilliant clinicians. So I guess we need to have a total reorientation of medical education. Our society needs reformation. At the same thing, that when you look at the vulnerable age groups, right, it's peer pressure. And the role models in society, whether it's our celebrities in movie, the Malayalam movie industry, or the rock stars, or even the football leagues, they need to come forward and be that powerful role models to say that it's cool to say no. I mean, that's what the kind of language I think we collectively need to adopt. So it's not one institution. I think all of us need to really come up together, otherwise it'll be too late.
Thank you, Doctor. And we had Sam prior to lunch explaining to us how, as a football professional, he has been intervening in Cambodia in a very powerful way. So what you mentioned now is already taking place, but maybe we need to have many more examples and more things happening locally back home. The second question is addressed to Linda. How are the rehabilitation strategies happening, recovery process being effectively handled in her country, and can such models be adopted here in India?
Well, I think we have challenges in our recovery programs in Sweden at the moment, but I think we know what we need to do, and I think that is the same case all over the world, that we need to focus more than purely on the drugs. We need to focus on the whole social sphere when we talk to people and try to motivate people to come into recovery and also to stay in recovery. And we have talked about it earlier here about prevention, that it's important to have something else to do. And I think that this is even more important because in Sweden, unfortunately, a lot of the times people go in for treatment, they go for 3 months, and if they are lucky, they have an apartment when they come home. And then they sit and look at a white wall. And who can expect anyone to start to build a life when there is no assistance? And they also get a paper with a phone number on to call. And if they are lucky, they also get a chance to meet with the counselor within 2 weeks. So I mean, we have to strengthen this, and we have to talk not only about the drugs, but also about the housing, the employment, the social connectiveness. And of course, also what I mentioned earlier, we have to believe that it's possible to recover. And the society needs to be welcoming these people back when they want to come back and contribute to the society. So I think that these are the key issues that I think is very similar all over the world, no matter if you live in Sweden or in India or in Nairobi.
Recovery process is too big an area to be covered in a few seconds, but Linda, thank you for telling us how it happens there and how the whole community supports them continually to sustain the effects of the recovery process. We have a question that probably all the panelists could answer, because one of the things that three of you particularly mentioned was that we need a scientific approach with a thorough data collection, going into find out how the situation on the ground is before we can really fine-tune the intervention. That was mentioned by three of the speakers today. The request is, how can this kind of a fact-finding or data collection be done with sensitivity to young people, particularly children and adolescents and young people who are very sensitive to being, shown on the media or their details being, shared. How can a sensitive data collection be done which is appropriate? So this is open to all. A quick answer on this.
So if you both permit me, So I think one which is agnostic to emotions is technology. And thankfully our society, like our state government, is very much pro-technology. We have got a good fiber optic backbone, especially using BharatNet, connecting all the panchayats in the state of Kerala. So the vision could be that in all our public schools and a kiosk or even an app based on your phones, where you have that advantage of a virtual anonymity. You can at least answer an FAQs or a key question to explain that are you into that box of certain behavioral changes. That could be the first example of a large scale. We could go to the grassroots level and put a mechanism of, and it should be a public driven program where the government, educational department and health authorities need to be at the forefront. It's just an idea.
I think the short answer to that is some robust research can be done. Like when we carried out our research, what we found was it's researchers who are more anxious about asking sensitive information than students themselves. Once they are guaranteed anonymity and once they come to know that the teachers won't know what they're writing about, that's the prime concern. Would teachers be supervising them and keeping an eye? So robust research based on ethical research principles can be carried out under strictly anonymized conditions, and that gives us high quality and research and rich information.
One point I wanted to add was that the research can be done not only on the usage patterns, but also on the conceptual things that they are having. So, for example, say in the industry of films, they always say that if you have a puff, or they say that scripts that have been written under the influence of probably cannabis or ganja has been one of the most successful scripts. So they say it is creative smoking. So when you smoke, you get some ideas, very good ideas, out of the box ideas. So when a person is coming into that, you are getting some sort of ideas. Similarly, lot of such ideas are being planted into the mind of students, youth. Even there are people who are saying that you can perform well if you take some drugs. So such sort of misconceptions are being fed into the mind of children. Of course, there is some fact that if you take a puff, probably you may get a weird idea. Otherwise, you may not get. But the first thing that alcohol probably does is to reduce the cerebral inhibition. So you think a lot of things, otherwise you are inhibited by your brain. But there are other ways and means in which you can prop up your creativity. you get a high. So we have to first get what sort of misconceptions have been gone into the mind of the children. And it is very difficult to fight these things because they are happening through the back of the door. Because especially when you are fighting drugs as compared to alcohol. Alcohol is a legal thing, so you are fighting it differently. But drugs are always illegal, and all these misconceptions and these things are being fed through a secondary channel, which you are not able to identify. By word of mouth, it is being spread that these things are there. So it is also important when we are doing a research to identify what sort of such misconceptions has gone into their mind. Because when we are devising a campaign to address, to dispel those misconceptions, we should be very clear that what all things have gone into their mind.
We shall listen also to Linda. She has also some very important insights to share with us on sensitivity in research, especially with younger populations.
I don't know if I have that much to share, but we have done drug surveys on young people in Sweden since 1971. We have done that, and we always done it in school settings. So we cooperate with schools, and they give the survey to the kids, and they get 40 minutes to fill it out, and then we get all the information we need about drug prevalence, about both alcohol, tobacco, and illicit drugs. We also ask about risk and protective factors, so we need all of that. That, of course, we have to have a cooperation with schools, but so far, since 1971, it has worked. And then also one precondition is that it's anonymous, yeah. So you also have to a bit rely on the teacher, because you hand it in, and you hand it in an envelope. The teacher can never ever see that. And then it goes into central office of Sweden, and they handle the data. And I also know that Harvey has great experience in gathering data, so you have more people to ask around here about that.
When I looked at the topic of this panel, it was prevention, care, and rehabilitative intervention. The first thought that came to my mind was gone away and gone forever. But after listening to these experts who have a lot of experience on the ground, we come to know that the picture, though it might be grim, we still have a lot of hope, provided we intervene effectively. So I thank all the panelists for their enlightened interventions and sharing on this panel, and also for the queries that came which clarified issues. Thank you so much.
Thank you, panelists and moderators. Now, we have come to the most important part of SAFE Forum 2018. A woman with dedication, passion, and focus, Diana Joseph, founder and managing trustee of Fourth Wave Foundation, started her career in development sector with Action Aid and had over 10 years of experience working with international organizations like UNESCO. Before starting with Fourth Wave, she has been actively championing the cause with special focus on children and teenagers, issues of right to education and child rights. A researcher by interest and passion, she has also co-authored several papers and journals which have been presented at various international forums. With a flair for excellence and commitment to see it to the end, we welcome Diana Joseph, our director, the backbone of SAFE Forum 2018, to moderate this discussion